Good evening. Good evening, everyone. First of all, I would like to thank JB Chemicals for giving me this opportunity to share the recent insights about the newer molecule that was recently introduced in our cholesterol management armamentarium, that is inflexeron. Um, so, basically, we have to remember that we are in the midst of a biggest pandemic, the pandemic of biggest non-communicable diseases. If you see the recent death rates happening in not just in India, throughout the world, it's mostly because of the non-communicable diseases. These are accounting for most of the deaths that are happening all over the world. Hello. Next slide, please. Yeah. This slide aptly highlights the this burden of the cholesterol and dyslipidemias in India. On the contrary to the age-old thought, where we used to think that rural India has less amount of dyslipidemic burden, but this paper, of course, not yet published in Lancet, it was just an ICMR data, shows aptly that there is no difference in dyslipidemia when you compare both rural and urban India. That means both rural and urban India has the same amount of disease burden. That means almost 80% of rural population and 82% of urban population has the dyslipidemia burden. So, as we all know, dyslipidemia acts as a precursor for development of future coronary artery disease or cerebrovascular accidents or peripheral vascular diseases. So, this acts as a precursor. So, if we control this dyslipidemia in the early stages, then we can prevent the patients from landing into those problems. Next slide, please. And this slide shows how those lipid levels and disease burden, CV event rates are related. So, starting with the age-old trials, which were done in 1990s, starting with Jupiter, which was done in primary prevention group, uh, to the most recent trial, that is Wascom's trial, which was published recently in 20, I think in 2023. All these trials show that there is a linear relationship between the LDL cholesterol levels and the absolute CV event rates. That means if the LDL levels gets increased, so is the CV event rates. So they go hand in hand with each other. So if you happen to have a high LDL cholesterol, you are at a greater risk of developing cerebrovascular or cardiovascular events. So all these trials show the same thing. So same important thing. That means you have to put down your cholesterol or LDL levels for you to reduce your CV event rates. That's the most important point that was aptly highlighted in this slide. This slide also shows another important fact that be it a primary prevention group or secondary prevention group. That means if you are already having cerebrovascular accident or if you are not having cerebrovascular accidents previously, both the groups, that means primary prevention group and secondary prevention group, all groups behave the same way. That means if your LDL cholesterol is increasing, you are at a more risk of developing further cerebrovascular accidents. Next slide, please. So, what do guidelines say uh, about LDL cholesterol and its targets and the various kinds of treatments that we have to offer to the patient? So, this is ESC guidelines, which was published in 2019, which aptly says that all you have to do is risk stratify the patient, and know which group he belongs to, whether it is low or medium or high or further very high risk. So, know your patient and risk stratify the patient and then treat accordingly. So, what is the difference between medium, high, and very high risk group? If you happen to have that type 2 diabetes mellitus, which is of duration less than 10 years, you fall in moderate risk group. If you have diabetes that is with a duration more than 10 years, or if you have hypertension with more risk factors, or if your diabetes is less than 10 years duration, but you happen to have more number of risk factors along with diabetes, or if you happen to have a CKD with EGFR falling between 50 to 30 to 50, then all these people fall under high risk group and very high risk group. This was the recently added one that was done in 2019 guidelines, showing that if you happen to have a atherosclerotic cardiovascular disease, if you are having further more events in addition to your index event, then you fall under very high risk group. And the levels of LDL cholesterol for each group is predefined. That means if you are in low risk group, you should target your LDL cholesterol to be around 100 or 116. If you happen to have if you happen to belong to moderate risk group, you should target your LDL cholesterol to 100. If you happen to fall under high risk group, you should target your LDL cholesterol to around 70. And the recently added group or recently created group, that is very high risk group, for this group of patients, we should target their LDL cholesterol to be around 55. So this is the new change that was done in 2019. On the contrary to what these guidelines say, our guidelines, that means CSI guidelines, what do they say? Next slide, please. I would say these are little more aggressive in adding further more groups to the already existing group. That means they created a very high risk group of patients. That means they have taken all those who had established atherosclerotic cardiovascular disease, and if they happen to have involvement of multiple vascular territories. That means involvement of cerebral vessels or peripheral vessels. That means their tibial vessels or peroneal vessels or femoral vessels. If they happen to have atherosclerotic burden in all the vascular territories, and if they are having multiple events in the similar territory, in the same territory, all these patients fall under very high risk group. That was the one modification. And what did they do is they further modified or further made the targets aggressive. That means they suggested us to go for higher or lower LDL cholesterol. Uh, that means LDL as low as less than 40. You should target for very high risk group. The target for this group is LDL cholesterol should be less than 40. I should say this is so aggressive guidelines, but still we are seeing so many population belonging to this category. So we are seeing that even their cholesterol levels is at 50, but still we are seeing the patients have coming with second or third vascular events. So that means I think these guidelines have done enough justification in saying that we should be aggressive in treating when it comes to cholesterol if the patient is having more and more number of events. That was one apt and correct modification that was done by our Indian Cardiovascular Society of India guidelines that was published in 2023. Next slide, please. So how you should go about in the management of dyslipidemia when the patient comes with ACS. So on the contrary to the age-old belief, you have to do the cholesterol levels within 24 hours, and you can do non-fasting cholesterol levels. That is as good as fasting lipid levels. That was the main point that was highlighted in previous European and American guidelines. So taking a leaf from that, these guidelines also state that non-fasting lipid levels are as good as fasting levels. And one thing they add is you have to do it within 24 hours. And if once getting those cholesterol levels, you have to start these patients on high dose statins along with ezetimibe, whether it be 40 mg rosuvastatin or 80 mg atorvastatin, along with ezetimibe should be given to all ACS patients. So, and concomitantly, you should look for LDL cholesterol levels at 4 weeks and see whether their LDL cholesterol levels is getting below 55 or not. If you are not getting or reaching your LDL goal after 4 weeks, you can consider adding either bempedoic acid to the already existing regimen and see further after 8 weeks. That means you can wait for 4 more weeks to see whether your LDL goals are reaching or not. If your goals are still above, or if your LDL cholesterol is still above 55, you can consider adding either a PCSK9 inhibitor or inclisiran. So I would say these guidelines definitely pave a correct way for us to how to treat the most high risk patient, that is ACS, because ACS is one situation where these patients will have worst outcomes. If you treat or target the cholesterol early with a multi-drug regimen, that is the best way to put forward in treating these kind of high risk patients. Next slide, please. But given all these guidelines, what do real world evidence show us? This is the paper that was published uh, in Interventional Journal of Cardiology with the cardiovascular risk and prevention. This aptly shows that even though guidelines say that we should be aggressive in managing lipid levels once the patient presents with acute coronary event situation, but still the real world shows that there are several lacunas in this. This shows that almost after 3 months of follow-up, only 80 patients stick to the similar kind of regimen that was offered to them. And after 6 months, it showed that only 65% are adherent to high dose statin regimen. And if you take, for example, like after that, that means after 1 year of follow-up, high dose statins are being used in only 33% of patients. So you should be wondering why all these things are happening. What is the cause for this low adherence in these kind of patients? There are several causes that were put forward to explain this variability. The causes that was put forward were: one is patient discontinuing the drug because of side effects, or it might be due to the physician inertia, or it might be due to the cost. That means most of the times we may say they are adding a lot of cost burden to the patient. That might be the reason why the patient is discontinuing the drug. And also there is lack of effort from the so-called social media, or the media that was existing now, which is not showing a proper way how to deal with these kinds of patients. They still uh, not enough effort made to show that high LDL cholesterol is accounting for the high disease burden. Next slide, please. So, so I think it's not the physician inertia or patient, cost, that is accounting for this kind of lack of effectiveness or discontinuation of these non-adherence of these statins. I feel it might be also be due to inter-individual variability in LDL cholesterol reduction. That means if you happen to use similar kind of drugs in, let's say, for example, different kinds of patients, you happen to see all those similar dosage of drug are not reducing their LDL cholesterol to what they are supposed to bring in each and every patient. You can see inter-individual difference. That means in one patient you can see almost 50% reduction of their LDL cholesterol, but in some other patients they are not reducing their LDL cholesterol to less than 50%, which it is supposed to do. That means it might be due to different kinds of genetics that is playing around these statins usage. That might be one another reason, or as I said, the treatment discontinuation or statin intolerance. Statin intolerance, on the contrary, which we used to believe that statin intolerance might be around only 5 to 10% of patients, but recent studies aptly shows that that is around 20 to 30% of patients receiving especially higher dosage of statins. So what do they complain of is mainly the muscle aches. Muscle aches or their LFT abnormalities. All these things might make the physician to discontinue or go to lower dosages of statins. So we should do a proper management in this category of patients. To the patient who belongs to this category. And how means to say time of switching also. That means you should be very much judicious in switching the patients from one modality of treatment to another modality of treatment. If the patient is not bringing his LDL cholesterol levels with, let's say, with high dose of statins, you should be prompt in introducing another modality of treatment. Let it be estimate or bempedoic acid or PCSK9 inhibitors. Ultimate goal should be to bring down his LDL cholesterol to his targets. Next slide, please. Yeah, this might, whatever we talk, this poor adherence might also be due to the number of doses which they might have to receive. That means this slide aptly shows that these are the number of doses that the patient might have to take to complete 1 year of usage of the statins. So if you add a drug which increase number of dosages, there are several chances that he may forget or uh, he may be slacked in receiving all those kinds of doses. So if you give or offer the patient a regimen which happens to bother him only once or twice a year, that would be the most effective way of treating this kind of patients without reducing the pill burden. So this slide aptly shows that if you are happening to reduce the number of dosages or pill burden to the patient, there is high chance that he might follow the regimen and continue it for a longer period of time, getting the apt benefit of this therapy. That means getting their LDL cholesterol levels to their targets, and adherence, simultaneous adherence, which is the main issue with this kind of patient, also gets increased. Next slide, please. Yeah, next. Yeah. So next, next, next. Yeah, yeah. So previous one. Yeah. Stay there. So this slide effectively shows the lipid variable. That means you happen to take a drug which acts only for limited period of time. Let's take, for example, in this case, like PCSK inhibitors, which should be taken for every 14 days. That means as long as the day, that means the deadline, that is 14th day, is crossed, your efficacy of these drugs comes down, and so is your LDL cholesterol. That means LDL cholesterol start rising again viciously after these 14 days, again to their normal level as early as within 5 to 6 days. So if you are lagging in this period, that means uh, you will see more and more cholesterol accumulating in this lag period of time. So you should be judicious. You should make certain modifications to your regimen, that you should make it so palatable to the patient that you should choose a drug which acts for longer period of time, that stays in the body, and it will continuously keeps the LDL cholesterol for a greater period of time. So that's where our inclisiran or RNA silencing drug plays a major role. And as your LDL cholesterol creep on after in this lag period, you are at an increased risk of again having acute coronary event or any kind of cerebrovascular event or even the death. So this LDL variability, whether it is due to lack of adequate dosage or due to lack of adherence or due to several other reasons, is making you to go to have a higher event rates. Next slide, please. So this slide shows how these inclisiran and various drugs act in reducing the LDL cholesterol. So statins, as we all know, is a HMG-CoA inhibitors. It reduces the HMG-CoA enzyme. It inhibits it, and thereby increasing the more and more number of LDL receptors, so that more amount of LDL is absorbed into hepatocytes, and further they are damaged and excreted from the body. And if you take, for example, like PCSK9 inhibitors, PCSK9 is the one which internalizes those LDL receptors and make them lysed in lysosomes. So that you won't have any LDL receptors getting attached to the hepatocyte surface. So if you happen to give a drug which inhibits this PCSK9, like that is PCSK9 inhibitors, if you happen to give them, that will damage this PCSK9 in the body, and that will make more and more amount of LDL receptor showing up on hepatocyte surface. And on the contrary, because this PCSK9 inhibitors needs to be given for every 14 days, you have another drug, that means a inclisiran, that is a RNA silencing drug, uh, because of which action you might not be able to produce the PCSK9 itself. So there won't be an agent that is damaging this kind of LDL receptors, so that you will ultimately have end up having more and more number of LDL receptors showing up at the hepatocytes, making their LDL cholesterol go down as low as less than 50 or less than 30. If you add, if you take these drugs in addition to the baseline statins or estimate. So this shows that this is an RNA silencing drug. Because this is an RNA silencing drug, this effect of this drug can stay for a longer period of time. Next slide, please. This, as I said, this inclisiran works specifically in the liver. It mimics the body process of RNA interference, which is restricted to the cytoplasm, and it further reduces the production of this PCSK9 itself, so that more and more number of LDL receptors are available for them to be shown up on the hepatocyte, so that they can reabsorb the LDL cholesterol and further make them excrete from the body. Next slide, please. Next. Yeah. So inclisiran is indicated in adult patients with either primary hypercholesterolemia, either it be heterozygous or non-heterozygous, or with mixed lipidemia as an adjunct to the diet, or it can be used in combination with statins or other lipid-lowering therapies in patients who are unable to reach their LDL goals, or it can be used alone or in combination with other lipid-lowering agents in patients who are statin intolerant or for whom statin is contraindicated. Next slide, please. Next slide, please. Yeah. This slide shows how this inclisiran needs to be administered. This is just a 1.5 ml injection which needs to be given subcutaneously. It delivers almost 300 milligrams of inclisiran. Where water acts as a diluent, with sodium hydroxide and phosphoric acid taking care of the pH that needs to be maintained once this drug is injected for it to act for prolonged period of time, and it can be stored at room temperature itself. So coming to the dosing regimens, a lot of trials were done to know what's the apt dose for this inclisiran, and they have come to the conclusion that if you do give an initial dose, and if you repeat it after 3 months, right after 90 days, if you repeat again the similar kind of dose, and further doses can be given at 6 months intervals. So adding this second dose at 90-day interval will further reduce your LDL cholesterol to a maximum extent. That's what these Orion trials have shown us. Next slide, please. So, as I said, you can see if you add a second dose at 90 day after the 90 days after the index injection, then you have lowest possible LDL cholesterol levels, whether it be PCSK9 or LDL receptors. PCSK9 gets reduced to the maximum extent if you happen to give one more inclisiran at 90-day interval, and simultaneously your LDL receptors also shows up to the maximum extent if you add a second injection at 90-day interval. Next slide, please. Yeah. So, on the contrary to the majority belief, there are no drug interactions for this drug. Unlike the statins, which have so many side effects, whether it be on muscles or liver, these drugs doesn't have any interactions with any organ whatsoever, and you can co-administer with statins. You can freely do that. There are no limiting toxicities with this drug. There is no genotoxicity or carcinogenicity, or there is no effect on fertility or embryonic development. As this drug targets the RNA, there is no many people may think that this may alter the genome itself. That might be that might further lead to fertility issues or embryonic development. On the contrary to all these beliefs were proven to be wrong in majority trials where they couldn't found even one affecting the fertility or embryonic development in the patients who are receiving this kind of drugs. So there is no adjustment. Dose adjustment is not necessary if you happen to have renal or liver dysfunction, and only a mild injection site reactions, that too were less than 55% were reported as the adverse event in majority trials. Next slide, please. So these are the various trials that were done uh, on this drug, that means inclisiran, starting with phase 1 trials, that is Orion 6, 7, 12, and in phase 2 they included atherosclerotic cardiovascular disease patients also in Orion 1, and homozygous familial hypercholesterolemia were included in Orion 2, and long-term effects of Orion extension was done in Orion 3, and CVOT outcomes and were evaluated in Orion 4, and homozygous familial hypercholesterolemia patients were evaluated in Orion 5, and their long-term effect extension was seen in Orion 8, and so on and so forth. The recent one is Victorian preventive trial, which was done in high-risk primary prevention population, uh, but that was recently discussed in ESC Congress 2024. Next slide, please. Yeah. This is the phase 3 study. That means Orion 9, 10, 11, and 5. So, what do they include? In Orion 9, they included heterozygous familial hypercholesterolemia patients. In Orion 10, they included established atherosclerotic cardiovascular disease patients. And in Orion 11, they included even those who have atherosclerotic cardiovascular risk equivalent, not just atherosclerotic cardiovascular disease patients, but also those who have the risk equivalence. That means if the patient has CKD or diabetes mellitus that is more than 10 years duration, they included all these risk groups also. And in Orion 5, they primarily evaluated homozygous hypercholesterolemia events patients. All these patients received inclisiran 300 milligrams or matching placebo. The period of treatment was 18 months, and they were almost completed. And we will discuss their results in the further slides. Next slide, please. Yeah, this is Orion 9 study, where, as I said, they included heterozygous familial hypercholesterolemia patients with their LDL cholesterol more than 100. They included almost 400 population, and the baseline cholesterol was around 150. Baseline LDL cholesterol in this group was around 151, and uh, the most important finding is that PCSK9 levels decreased by 60%, and even they were able to reduce the LPA by almost 13 to 10 to 15%. There was no drug in our cholesterol drug treating armamentarium which has the ability to reduce LPA to this magnitude. So this is one promising result that was found in this study. And in addition to that, they were also shown to reduce the cholesterol to the extent of 26% and non-HDL cholesterol to the extent of 36%. Even in Orion 10 and 11, all these results were replicated to the same extent. So, saying that all these drugs are equally beneficial, whether it be homozygous familial hypercholesterolemic patient or those with established atherosclerotic cardiovascular disease or homozygous familial hypercholesterolemic patients. Next slide, please. Yeah. So, as I said, inclisiran thereby demonstrates its efficacy and its continued effort in reducing the LDL cholesterol to maximum extent without any inter-individual variability. So you have to mark this. That means LDL cholesterol, as long as you use this drug, is consistently reduced because of its one longer duration of action, less number of dosage requirements. I think these two are the most important facts in reducing consistently the LDL goals, LDL levels in a patient. So they showed that almost LDL cholesterol is reduced to the extent of 50% and effectively getting the patient all the benefits out of this. Next slide, please. So, as I said, it consistently reduces the total cholesterol levels, FOB, non-HDL cholesterol, triglycerides, and LPA. As I said, it reduces to the extent of 20%. No other cholesterol lowering drug has the ability to reduce LPA as much as this drug does. Not just that, it also increases the HDL levels. So there are no established drugs which have the ability to increase HDL. Although they say niacin has the ability to increase HDL levels, but it comes at a higher side effects. It comes with higher number of side effects. So that's the reason why drug was taken out from the market. Next slide, please. Yeah, this was a pooled analysis of phase 3 trials. That means 9, 10, and 11. All these trials put together, they got almost around 2,000 population, and they found that the adverse effects were very, very, very low in those who are using inclisiran. The major ad effects, major or serious adverse side effects were very much less, and it was comparable to that of placebo. And on the contrary, arthralgias, urinary tract infections, diarrhea, pain, extremity, they were all comparable in both the inclisiran and placebo group. Next slide, please. So this is an outcome study to look at the long-term outcomes in these patients. That means around all these trials put together, they found around 3,000 population, and they wanted to see what is the long-term effects of these patients in Orion 4 and Victorian 2 preventive trial. This is the open label extension trial. That means that was done as Orion 3 and Orion 8. Next slide, please. So they show that the inclisiran is consistently reducing the MACE. MACE means like major adverse cardiovascular event, which includes death, MI, and cerebrovascular accidents. So when compared to placebo, it has the ability to reduce the MACE by 26%, and fewer MACE rates were reported when compared to placebo, and even the individual risks of this MACE, that means like MI and stroke, were also less reported in inclisiran group when compared to placebo. Next slide, please. So this is how the study went, how they designed. That means Victorian initiate trial, which happened to take primary prevention group patients. That means who didn't have any established atherosclerotic cardiovascular disease. Uh, they started these patients and randomized into two groups. That means one receiving the placebo and one receiving the inclisiran. And they first dose was given first dose was given and first dose was given after 90-day interval. Again, the dose was repeated and further doses were given at a 6 months interval. Next slide, please. Yeah, this was published in JACC journals. That means this shows that the co-primary endpoint, That means like percentage change in LDL cholesterol level was consistent throughout the period of treatment. That means LDL cholesterol levels were consistently low throughout the 300-day interval. Next slide, please. So here you can see this is showing up the results. That means inclisiran is reducing the LDL cholesterol levels to the maximum extent. That means less than 70 levels of LDL cholesterol was achieved in almost 80% of patients at 90-day interval. And not just that, patients are reducing the cholesterol to less than 55 milligrams per deciliter of LDL cholesterol in almost 70% of patients in all categories, in all timelines, whether it be 90-day, 180-day, or 270-day, or 300-day timelines. So it is consistent in reducing the LDL levels. Next slide, please. And the primary endpoints, that is statin discontinuation. This also, as expected, inclisiran fares better when compared to the placebo. That means the non-inferiority margin was met. Next slide, please. So this aptly establishes the efficacy. That means LDL cholesterol is consistently reduced to the extent of 80% of patients, and it also establishes the safety of inclisiran. That means major adverse side effects were comparable to placebo with the usage of this inclisiran. Next slide, please. So, what do ESC 2024 Congress say about this inclisiran? Next slide, please. That means basing on um, this ESC data from Victoria Initiate trial, they found that all group of patients, whether it be white or non-white, Hispanic or non-Hispanic, male or female, all group of patients, whether it be like whether if you stratify the patients basing on their income levels or basing on their EGFR category, all these patients are achieving the similar kind of results with the usage of this inclisiran. There is no difference whatsoever that was noted. Next slide, please. So, in conclusion, Victoria Initiate trial demonstrates that inclisiran first that as a first strategy is more effective than usual care in achieving the LDL reduction and goal attainment across diverse patient subgroups, including those with patient potential healthcare inequalities. And the safety profile of inclisiran was comparable to the usual group, supporting its use as the first line of therapy in patients with ASCVD who fail to meet LDL cholesterol with statin alone. Next slide, please. So this is a summary slide. That means putting it all together, they say that inclisiran containing the low LDL cholesterol reduction is also effectively reducing or stabilizing the atherosclerotic plaque burden. This was one trial which showed that it is not just reducing the LDL cholesterol levels, it's also concomitantly stabilizing the plaque. So in this study, what they did was they did NIRS in all the patients. They took all the stable heart disease patients in the baseline. They did NIRS, and they found that cholesterol or plaque burden was seen in almost 60% of patients, and with the usage of this lipid reducing therapy, that means that inclisiran, it is able to reduce the plaque burden. That was confirmed with the usage of NIS after a follow-up of almost 15 months interval, which shows that it consistently reduces the uh, not just the LDL levels, but also stabilizing the plaque by reducing the plaque burden. Next slide, please. So, the estimated impact of inclisiran treatment on hyperlipidemic prevalence and cardiovascular disease. events in NHA NES dataset says that the eligibility of US population, this estimated uh, the potential number of patients who might be at benefit by receiving inclisiran. So they state that they have taken all the patients who were above 18 years with dyslipidemias, and they found that, next slide please. Yeah, almost 3.9 population, 9 million population were at the risk of uh, having dyslipidemia, and they found that almost 5.07 million with LDL cholesterol, or 0.25 million with reduced HDL cholesterol levels, or 1.2 million with elevated total cholesterol, or 0.65 million with elevated triglycerides. All these patient categories would be uh, achieving the greatest impact of their LDL cholesterol or dyslipidemia reduction with the usage of this inclisiran. They found that with the usage of this drug, they happen to reduce, it was projected to reduce the CVD events by almost 5.2% uh, over a period of 10 years. That means inclisiran treatment in eligible US adult population may substantially reduce the hyperlipidemia prevalence and CVD events because of its uh, potential potential benefits. That means lesser number of dosage requirements and all that. It is able to achieve greater benefit with the usage in the population as wide as US population. Next slide, please. So this concludes my topic. I would be happy if there are any questions.